Okay, it is 3 o'clock Eastern Standard Time, and this is another edition of YouTube Live with Dr. Mitchell Yass. Today, we will be discussing the mechanism by which you can prevent yourself from getting an unnecessary total hip replacement. This is going to be a tutorial. This is going to be an opportunity for people to learn about the anatomy of the hip, about how to interpret the symptoms you're experiencing so that you can properly establish what tissue is in distress eliciting your symptoms, and also to discuss the typical types of diagnoses that people are given when they seek medical attention for pain in the hip region, which typically ends up relating to arthritis of the hip joint, the famous concept of bone on bone, and oftentimes a labral tear. So that's basically what we're going to try to go through. I'm going to try to, I've got a lot of visual information. I've got pictures and illustrations, and I hope that this is going to help people to understand the hip joint more clearly so that they are more prepared when they're going to a medical practitioner to address the issues of the hip region, so they have a better understanding of what's going on so that they can't be so quickly coerced into the idea, oh, I need a hip replacement at first blush. The number of hip replacements that are being performed has skyrocketed. I believe in 2010, it was estimated there were like 300,000 being done a year. And it's going up and up and up. And they're estimating through the Orthopedic Academy that they plan to be doing 1.2 million hip replacements a year by the year 2060. 1.2 million hip replacements a year with something like 300,000 to 400,000 revisions. Most people who know somebody who have gotten a hip replacement also know that these same people have typically gotten a revision to the original hip replacement within a month, 2 or 3 months from the original surgery. And the premise behind getting revisions was the idea that at some point the prosthetic components might wear out, and so new components would have to be added. But this was discussed as being somewhere in a 15 to 20 year range. So I don't think anybody in their right mind would actually be able to attempt to justify that you're wearing these components out in just a month, 2 months, or 3 months from the original placement of the prosthetics. The more interesting aspect of this is that the reason that the idea of the revision is being visited is because the person is having the same exact pain after the original hip replacement as prior, and the rationale of the surgeon is that, well, the cement didn't hold well, or the prosthetic isn't fitting properly, or the prosthetic came loose. And that's the rationale for the hip replacement revision. So I guess the fact that they're occurring at such an incredible frequency from the original surgeries, you would think that the logical progression would be to put a moratorium on these original hip replacements until they could figure out why, if it is true that the prosthetics aren't fitting correctly, that the cement isn't holding, or that the prosthetic just isn't working in the way that it should. It should be very scary to anyone who is contemplating getting a hip replacement that so many revisions are being performed. It should hopefully make you think twice about the legitimacy of the diagnosis that the pain is coming from the hip, the actual structure of the hip joint, so much so that even after replacing the surfaces of the hip, the person continues to have the same level of pain. which is the reasoning supposedly behind why people are getting these revisions. So it's a very, very scary time, probably the scariest time for someone to have pain, because of the fact that surgery has just accelerated. So, and I think that's primarily logically because the amount of reimbursement for any particular surgery has plummeted so much so that for the surgeon to sustain the income that they had been generating, they probably have to increase the amount of surgeries being performed. So another very, very interesting element of this is the fact that there are fewer and fewer actual independent medical practitioners. Medical practitioners are now becoming salaried employees to hospital corporations. I can primarily speak of Long Island and New York, where I'm from, and there were 3 primary hospital corporations that developed. It was Winthrop and North Shore, and the one all the way out east. And so basically what happened was these corporations began to eat up all the varying types of specialists that were performing as independent contractors, and they became employees to the corporation, which is to say now that the corporation dictates what the individual will do. And in fact, there was a gentleman, an orthopedic surgeon, who identified this and in fact stated that the orthopedic surgeon no longer has control over how many types of surgeries they're performing here, that in fact, the hospitals are telling them, you need to perform 7 hip replacements and 5 knee replacements today. And it's not even up to the thought process of the surgeon anymore. They're simply doing what they're told, because if not, they have the potential of being fired. And that's the scariest thing. You could have been in practice for years, and suddenly, if the corporation feels that you're not doing what they want you to do, they'll simply let you go, and you don't have a practice anymore. You signed your practice over to the corporation. So there's a lot of scary elements as to why there is this just massive increase in the number of not only original hip replacements, but also revisions. So this is a really great opportunity for people to understand the hip joint, how it works, the bones involved, the muscles surrounding it, and how to understand your symptoms so that you are better prepared to understand what's going on, so that you're not so quickly able to be coerced by a guy showing you a picture saying you're bone on bone when in fact you're not. So I think the first thing we can do is we will look at the hip joint itself. And so here we have a picture, and right there is your hip joint. The hip joint is comprised of the femur, your thigh bone, and the side of the pelvis where there's a socket called the acetabulum. So this is the acetabulum, and this is the femur. This is the neck of the femur, the head of the femur. So the head of the femur goes in to the acetabulum, and that is what creates the hip joint. Those are the 2 bones. Now, inside the socket is a fibrous cartilage ring known as a labrum. So inside here, there is a labrum, and the purpose of the labrum is to keep separation between the acetabulum and the head of the femur. You never want them touching, because as you're moving your hip, however you're moving your hip, the head of the femur must be able to glide inside the acetabulum, the socket. So there always has to be a space, and this is the whole premise behind determining whether in fact you are bone on bone or not. If in fact you legitimately were bone on bone, which there is a physical presentation of that, then there would be no way of the femur to move on the pelvis, and you would have a massive loss of range of motion. there is this false presentation that pain represents an indication of being bone on bone. It is not pain, because I can simply hit you with a baseball bat. Clearly, that would incite pain, but that is not a representation of being bone on bone. The only true physical presentation that represents being bone on bone is the idea of having a major loss of range of motion. As I said, without the labrum, the one-way labrum, which would allow the head of the femur to touch the socket itself, which would represent bone on bone, there would be no way of the hip joint moving. You would have a major loss of range of motion. And at that point at which you couldn't move it, it would feel like a bone's hitting another bone, stopping range of motion. It has to be made absolutely clear that the only true indicator of being bone on bone at the hip joint is a major loss of range of motion. And at the end of that range of motion, it feels like a bone is hitting another bone. Let's be absolutely clear. Pain, regardless of the severity, is not a representation of being bone on bone. So let's kind of talk about, we'll go to the next area. I think that kind of explains the bone structure of the hip joint. Let's kind of talk about what muscles surround the hip joint. So here is another picture, and this is actually representing, so the hip joint is actually right here. Here's the hip joint. This is the femur heading down, right? And this is the top of your pelvis. This is your butt. This is the gluteus maximus muscle. You can see it says gluteus maximus muscle. So that covers the entire gluteal region, and the gluteus maximus actually runs, it was cut back to show you, it actually runs to the hip joint. And so do all these other muscles. If you notice, they're all running to the hip joint that are attached in the gluteal region. So what do you learn? If you have pain from the pelvic rim all the way along, where everyone talks about the SI joint. The SI joint is the joint between the sacrum, which is the sacral spine, the portion of the spine below the lumbar spine, and the ilium, the actual portion of the pelvis. The pelvis is comprised of three components. So the SI joint would be right here. And as you notice, there is muscle that attaches right at the location where the SI joint is represented. So just because you're having pain in that region doesn't represent that you're having an SI joint pain. In fact, joints typically don't cause pain unless there's a loss of range of motion. And you could test the range of motion of the SI joint. Okay. Diana is on, and she said, many of my friends have had these joint replacements, and it's such an invasive surgery. It's terrible. The recovery is months and months, really bad. That is very true. And the reason that the recoveries are so bad is because there were muscular deficits which were really creating the symptoms. And as a result of that, the post-surgical symptoms of swelling and pain led to a greater loss of weight bearing, which led to greater weakness and straining. That's why the person typically has more pain after getting a hip replacement. It is because the cause originally was muscular, and the surgery only led to a greater inability of the muscles to support you, so they strain further. So going back to this idea, so here's the gluteal region and here's the hip joint. You can see all these different muscles, and we'll start to name them. But this is the areas where people are typically having pain. So the only person that you'd ever think or consider that the cause of their pain is from the hip joint itself is if the pain was directly at the hip joint. Look at the vast area we're talking about. The sides of the thigh, the groin, above the hip joint, the gluteal region. All of these areas are typically where people are having pain. All through here, they get an x-ray which shows some arthritic change here, and they're told that that arthritic change is the cause of pain anywhere else. That's the great fallacy. If arthritis was causing pain in the hip joint, then that would mean that the pain should be in the joint itself. For so many people, they think that the hip joint is here. Most people have no idea how to identify their hip joint. I've had people who have actually told me that they think their hip joint is in here, and that is because they're getting groin region pain, right? They'll actually get pain in the groin, and they think, oh, or somebody certainly conveyed to them that that's where the hip joint is. This is your hip joint all the way out here. So unless your pain is on the lateral aspect of your thigh, if this is the pelvic rim, you have to figure 4 inches down. You could literally put your hand on the pelvic rim, then run your hand along the side of the pelvis, and you will feel a bone sticking out. That is the head of the femur going into the hip joint. This is your hip joint. So Dia wrote, okay, what about an actual fracture? Could that be where you might need a hip replacement? Yes, of course. So if that was in fact, if a fracture was causing pain, wouldn't it make sense that there had to be some sort of acute incident to lead to the fracture? The average person will not get fractures of bones arbitrarily. You're going to have had a specific trauma to lead to the fracture. And the vast majority of people I've treated over 27 years actually tell me when I ask them, can you think of a specific incident that brought on their symptoms? The answer is always no. Can you remember the specific time when your pain began? The answer is no. It comes on insidiously, slowly, and they can't remember a specific incident. That is because they strain a muscle, don't recognize they strain the muscle, and then they continue to try to weight bear and do functional activities, continuing to strain that muscle. And if they don't weight bear, or they get a chance to rest at night, they don't use the muscle, so the muscle has a tendency to not cause as much pain. And that's where the confusion lies for most people, that the cause of their pain is muscular, because you have these periods where you have pain and don't have pain, have pain and don't have pain. So it's very hard for an individual to correlate the fact that the pain is coming when they're weight bearing. As a result of weight bearing, that's what incites the pain or makes it worse. And then when they rest or don't weight bear, they don't seem to have the level of pain that they did. That's where the connection has to be made. But for the average person, they don't get it. And certainly, if you go to a medical practitioner, they don't understand any of this premise. All they're trying to do is associate a structural variation identified on an X-ray as the cause of your pain, regardless of attempting to interpret your symptoms. You must appreciate that if you had pain anywhere here, in the butt area, in the groin area, along the lateral thigh, it doesn't matter to what extent arthritis was found in the hip joint. There is no possible way that that is the cause of that pain. That is so critical to understand. So just recognize it is the symptoms that help to determine what tissue is in distress. And in understanding the symptoms, you can establish whether the cause is muscular or whether it is structural. Let's say that this right here, this is the gluteus medius muscle, most critical muscle in the body. The reason being that this muscle, as you can see, it's attached to your pelvis in this entire area and then runs down to the hip. So you can imagine that if this was a stable point and this was a mobile point, it would be pulling it this way to the side. So what it's trying to do, if this is your thigh and this is your pelvis, it's trying to keep your pelvis level. Well, if it's weak, the pelvis can drop. And if the pelvis drops, your center of mass can move to the side, the opposite side. That will make you feel unstable. That will make you feel like you can trip. In terms of what happens above, well, if the pelvis has to be level for the spine to be perpendicular, any variation in the pelvis will change the angle of the spine, and that's what causes scoliosis. Even something like scoliosis is the result of a strained gluteus medius muscle. So if somebody were to have pain in this region, not directly at the hip joint, but above the hip joint, which you can identify, as you said, by putting your hand on top of the pelvic rim, running your fingers down the lateral aspect of the pelvis until you feel the bone sticking out. So if you had pain above there and you saw that your pelvis wasn't level, that should be a red flag that the cause of both the pain and the altered position of the pelvis is a strained gluteus medius muscle. Now, you'll go to an orthopedist, and he's going to try to convince you you're bone on bone here because some arthritic change was identified. And therefore, since the structural variation was identified while you're having a pain, it must be the cause. I wanted to show a study that was done. This is a study that was done, and this is from the, it's in the American Journal of Sports Medicine, and it was a study done, I'm not sure when, but what they did was they did a cross-sectional study of people who had absolutely no pain in the hip region. They scans were mixed randomly with 19 scans from symptomatic patients to the blind, to blind the radiologist to the possibility of patient symptoms. An abnormal finding was considered positive when 2 of 3 radiologists agreed on the premise. So this is fascinating because what they found was that, where is it now? What was found? Here it is. Magnetic resonance imaging of asymptomatic people, people who had absolutely no symptoms, revealed abnormalities in 73% of hips. 73% of the population who have no pain in the hip region can be found to have abnormalities, structural variations of the hip structure, the arthritic changes, and labral tears identified in 69% of the joints, almost 70%. So we're saying almost 3/4 of the population who have absolutely no symptoms can be found to have strong structural variations identified on diagnostic testing. What you want to appreciate is the fact that if you did the very same study, this was done on people who had no symptoms. If you did the very same study on people who had pain in the region, you would get almost the exact same results. Roughly 3/4 of the population in pain would be found to have arthritic changes and labral tears. And once you identify the fact that roughly the same percentage of people, whether they're in pain or without pain, have the structural variations, including labral tears, it means that the structural variations are independent variables to the pain. All it means is that, well, people who had no pain took an MRI, and people who had pain because they had strained a muscle in the region. That's the justification for the pain. And they happened to take an MRI while they were in pain. And that's why they were found in pain to have the same percentages of these structural variations. So let's say you were somebody who was one of these people who had strained their gluteus medius muscle and created pain right here, right? And I did an MRI and found that you had an arthritic change, right? That would show that that arthritic change is independent to this pain because just as many people with no pain had the same arthritic change. Here's the crazy part. Just imagine now you come to me, you find out about the Yass method, you come to me and I release your glute med and strengthen it so it doesn't elicit pain when you do activity. What would happen now? Now you'd be without pain. And imagine you went back and got that same MRI. The same arthritic change would be found. So you started off as a person with pain, and that structural variation was identified, and they said that that was its cause. Then I resolved your pain. Now you're a person without pain, and the structural variation is identified. If you understood that premise, then how could anyone say that the structural variation is the cause of your pain? It would be an absolutely insane idea to believe that. Diane wrote, this is just like spine. Everyone thinks it's the discs of vertebrae, and they do surgery, and it doesn't work. Right. This is all the same premise. That's the scary part about this. Whether it's the joint at the hip, the joint at the knee, the spine, I need people to understand that the MRI was not designed to find structural variations and associate them with pain. It was actually created to identify cancers in the brain. And I'm not sure where its use morphed into trying to identify structural variations and associate them with pain, but I can assure you no study was ever done to justify that it in fact can identify the cause of pain by finding structural variations. The first studies I'm aware of regarding the MRI were done in 1994, and it was actually done on people who didn't have back pain. And I believe it was like 98 people, and they found of those people, 70% had herniated or bulging discs. 70% of the people who did not have back pain at all were found to have bulging or herniated discs, which should have, at that time, 1994, we're talking close to 30 years ago, you would have assumed would have put a moratorium on the use of the MRI in identifying structural variations, because clearly you have to appreciate the way the scientific model is supposed to work. And the way it's supposed to work is that you create a theory, a hypothesis. In this case, we could say arthritis at the hip joint causes pain. And so you do a test and you try to find bunches of people who have pain and see what percentage of them actually have pain. And in this case, you would probably find like 70% of people with pain in the hip region have arthritic changes. So that looks like that's a very strong correlation, and therefore arthritis does cause pain in the hip region. But for every hypothesis, there's a null hypothesis. And the null hypothesis has to be accurate as well. What is the null hypothesis? Well, if you're saying arthritis causes pain, then that should mean that people who don't have pain should not have structural variations, such as, in this case, arthritis in the hip joint. And what did that study show? Roughly 70% of people with no pain have structural variations. If the null hypothesis, if the hypothesis and the null hypothesis are not proven, it identifies the attempt to correlate the two concepts as being invalid, baseless, independent variables. And that's what you find. It's exactly what you find. The idea of correlating structural variations to the cause of pain is baseless in every regard, whether you're talking about the use of statistical analysis, scientific analysis through the use of experiments where you're doing MRIs and all this other kind of stuff, whether it's from the clinical presentation, the most dangerous aspect, the most obvious aspect of this, which is to say that where you're experiencing your pain is not where pain would be experienced if, in fact, the structural variation was the cause. That is probably the clearest indication that that structural variation is completely independent of the symptoms you're experiencing. So, Darren, all this information needs to go out into the patient community. Everyone needs to subscribe to your channel. Super important. As a patient of yours, I know your stuff works. I just did a Skype evaluation with a woman from California yesterday, and we've been working together, and she actually, it's very sad, she had a surgery on her neck, a fusion, because she had pain around her shoulder blade, and there was no chance that that symptom could have been coming from the cervical spine or any disc or structural variation in the cervical spine. And sure enough, the surgery failed, and she ended up having pain for 30 years. Finally, she found out about me. I think it was through the PBS special. And we've been working for, I don't know, maybe a couple of months at best. And her symptoms have greatly reduced. I mean, it was preventing her from doing just about anything. And now she can do pretty much anything she wants up to the level of function that she's allowed herself to be able to perform. She needs to continue to push out to try to do more. And I've explained that to her. The beauty, if you have a muscular deficit and you get strong enough, then that's going to allow the force output of your muscles to be greater than the force requirements of your activity. And this is what allows you to do activity without straining, right? That's the beauty of the system. What separates the Yass method from any other method that exists is that the Yass method is the only diagnostic method other than the existing medical model of using diagnostic tests. I am not aware of any other method that is actually a diagnostic model. There are lots of treatment models out there. And the general premise of all of these treatment models are just try it. And if it doesn't work, all right, what can we tell you? That is far from a scientific model. As far as I'm concerned, the Yass method is as close to scientific as you can possibly get because it's utilizing the body's natural way of creating awareness of distressive tissues. What the hell do you think you have symptoms for? Why do you get palpitations of your heart? Why do you get an increased temperature when you get a flu? Why do you get difficulty urinating and pain in your back when you have a kidney stone, right? The idea behind all of these symptoms is that the symptom is being elicited by the tissue in distress, literally from the tissue, as a way of trying to create conscious awareness to you. It's actually trying to get you to understand that the tissue is in distress and it needs an intervention. That's why it elicits symptoms. And so the best way to understand what tissue is eliciting a symptom is to just interpret the symptoms. And what most people don't understand is that a bone elicits a specific symptom, a muscle elicits a specific symptom, and a nerve elicits a specific symptom. That's the magic of the Yass method, is that regardless of the tissue in distress, by interpreting symptoms, you can identify whether it's a bone, muscle, or nerve. It turns out, over 27 years and 15,000 people of empirical data, I have shown that in more than 98% of cases, the cause of pain is muscular. It's actually a muscle, and this will present in 4 primary ways. It will present as a muscle straining and eliciting pain, or causing another muscle to compensate and elicit pain. So the muscle itself elicits pain. It will show up by having pain in a joint, but not as a result of some structural variation, some change in the structure of the joint, but by a weakness or imbalance of muscles that connect to the joint, which causes a misalignment of the joint surfaces. The joint surfaces aren't moving in the way that they should. And as a result of that, the bones rub in a way that causes pain. So that's 2. Another one, which most people have no idea about, is that muscle refers symptoms. So a great example of this is that muscle. If we were to look at this muscle, the gluteus medius muscle, if you had pain in this muscle and I pressed on that muscle may actually refer symptoms all the way down the side of your leg. All the way down to the side of your leg. Let me see if I can show you this. I find this to be very, very interesting because most people think muscles will only cause pain where the location of the muscle is. That's why most people, if you feel a symptom running down the entire side of your leg, you're less apt to believe that it's muscular, right? Because, it feels like it's referred, and referred symptoms are always neurological. Trigger point chart, gluteus medius. So, if we were to take a look at this, and let me see if I can show you this. There you go. So if we were to look at this, if this is the gluteus medius muscle, Look how far down it can refer symptoms down your leg. That is a trigger point chart showing how the gluteus medius, this muscle all the way up here, can refer symptoms all the way down the lateral aspect of the leg. And it's fascinating because there has to be an understanding, and this is where the representation of symptoms is so critical, right? Because if you had symptoms running down the back of your leg, well, that's more representative of sciatica, right? If you have it running down the side of your leg, shit, man, the average person's going to say, oh, that's sciatica. But sciatic symptoms are in a specific location, the back of the leg. If it's on the side of the leg, by definition, it's a different symptom. It must have a different cause. And that's the type of stuff that I'm trying to get across to people. Now, let's kind of take a look at where the most common location for the recommendation of a hip replacement occurs. So this is the front of the thigh, and this is the groin. This is the groin in here, right? So most people will have pain somewhere in this region, the groin, the inner thigh. And they'll be told that arthritis of the hip joint is causing pain in the groin area, which is here. Now, you must recognize that what they're saying is that this cause here must be referring symptoms to here, right? Because the cause you're being told is here and your symptom is here. So if you wanted to confirm that groin pain is being referred from the hip joint, how would we try to establish that? We would have to lay the person on their side, and I would take my hand and I would force the head of the femur into the hip joint, pushing down on it and seeing if I can bring on the pain in the groin area, which is here. And I've treated thousands of people who were diagnosed with the diagnosis of bone on bone as the cause of their groin region pain. To prove to them it wasn't coming from the hip joint, I laid them on their side. I took my hand, jammed on the head of the femur, forced it in. They never got the symptom. So if you couldn't bring on the symptom that way, what if I was in here and I pressed right here, anyway here, and I brought the symptom on, right? If I'm pressing here, the hip joint's all the way up here. I'm pressing over here. So if I was able to press here and bring on the symptom, this would instantly disprove that the hip joint is the cause of the pain, because I'm pressing on where your pain is and I'm bringing your pain on, which is to say that your pain is what is known as point tender, meaning that the tissue that I'm pressing on is the tissue eliciting your symptoms. So in this particular case, you can see this is a muscle called the sartorius muscle. And here is another muscle called the gracilis muscle. So if I pressed in these two areas and I brought on the symptoms, yet I couldn't bring it on from the hip joint, the presentation of symptoms has just proven irrefutably that that arthritic change that was identified could not be the cause of the symptoms. Therefore, any attempt to get a hip replacement, when I pressed in your groin area and was able to bring on your symptoms, will guarantee prior to getting the surgery that the surgery will fail. It's not an opinion, it's a fact based on the presentation of the body's symptoms. That's why it is so critical for somebody who's considering a hip replacement to go to somebody like me who follows the Yass method means of interpreting the body's presentation of symptoms to be able to confirm whether the diagnosis given by the medical practitioner is correct or not. If you went to a physical therapist, would you get a evaluation that interprets the body's presentation of symptoms to confirm or refute the diagnosis of being bone on bone? The answer is clearly no. And that is because a physical therapist is not required by law to confirm or refute a medical diagnosis. They simply treat based on the medical diagnosis, which is pretty scary. The reason that I created the Yass method is because I went to medical school to get a physical therapy degree, and in fact got a doctorate, and recognized that if you're telling me that you want me to treat without confirming or refuting a diagnosis, I really don't know how you could do that in good faith. And that's why I went on and developed the method. Diane wrote, I know what you say about a strained gluteus medius to be very true. When I strengthened my gluteus medius, many of my pain symptoms went away. What's kind of interesting about Diane's case is that one of the things, as we talked about with the gluteus medius muscle, so if we're looking at this picture again, remember we talked about this is the gluteus medius muscle, and we said that if it's weakened and this is the stable point, this will fall, right? The pelvis will fall. It's trying to grab the hip joint and pull it this way so that it stays over the hip joint, right? But if it's weak and this is the mobile side, it will fall in and your pelvis will drop, which means that there's less space for the opposite foot to walk through, and you'll have a tendency to catch your foot, to trip. The other thing that can happen, as I said, is that you can end up having scoliosis. But if we now think of this as the stable side, what would happen if you look at this? Here's your thigh bone coming down, and when you stand on this leg, your knee is supposed to stay directly under your hip. Well, if the gluteus medius is weak, now this will have a tendency to come in, and you'll see your knee collapse in. Once the knee collapses in, it becomes very difficult to weight bear through the midline of your knee. So imagine that if this would have come in this way because the glute med is weak, then you're going to have this knee caving in, and you're going to see more of an angle in. In that being in, you will no longer be able to weight bear through the midline of the knee. You're actually going to be weight bearing more towards the inside of the knee. Therefore, muscles that sit on the inside of the knee are going to have to work harder to stabilize the knee joint because you don't have all the typical muscles available to do so. And what might happen is you might strain your hamstring, the posterior thigh muscle, which attaches over here. And in fact, that's what happened to Diane. Diane's complaint of pain was all the way down at the knee joint, but the cause of it was a strained gluteus medius muscle. And it was because the gluteus medius muscle being strained changed the way the force of her weight went through her leg. And instead of going through the midline of the knee, it went through the inside of the knee. Her knee had caved in. And you could see it when she single leg stood. As a result of that, she strained her medial hamstring. She was told it was going to be a structural issue and she needs a hip replacement, a knee replacement, all the other crap that goes along with this, when in fact, it was a change in forces due to a straining of a muscle. And that's what most people have to understand, that the variety, the primary reason people are having pain is because there's been an alteration in the forces that muscles create. And as a result, there's a change in the way your body is allowing your forces from gravity pushing down on you to go through your joints. As a result of that, you are going to change the requirements of different muscles to have to create force output. In most cases, more, like in this particular case, the medial hamstring, the inner hamstring, is going to have to do more than it was designed to do. It was never designed to take that load because you were designed to weight bear through the midline of your knee. So that's why that muscle strained. So you could work on the knee. You could get a knee replacement. Diane could have got a knee replacement. The reality is, if she never got the gluteus medius muscle strengthened, she would have never allowed that knee to come back so that it remained directly under her hip when she weight bared. and allowed the force of her body to run through her entire knee. The weight was diffused through the entire surface area of the knee as it was designed. 100% of the surface area took 100% of the load. And as a result of that, no muscle was overworking and her pain went away fairly quickly. So that's what you kind of want to have to understand about all this stuff. Now, all this stuff I'm talking about, does any of this show up on a diagnostic test? Let's say in Diane's case, would that medial hamstring strain show up? No, of course not. No chance in hell that was going to happen, right? And yet a structural variation would show up, an arthritis, a degenerative meniscal tear. And so as a result of that, that's how you get manipulated. These muscular causes never show up, and yet structural variations always show up, regardless of whether they're the cause or not. So as a result of that, if that's what's identified, that's what you're going to be diagnosed with, and that's what leads to all the treatments. The cortisone shots, the medications, eventually maybe you'll get a meniscectomy at the knee, maybe you'll get some sort of shaving of your labrum at the hip, maybe you'll get some shaving of the arthritis, but eventually the only alternative that the medical system is able to give at the hip joint ultimately is a hip replacement. And that's where you're leading, no matter how much you want to fight it, no how much you say, oh, it's never me, I'm not going to be that person. If you can't function and you have pain, which is undiagnosed or inappropriately diagnosed, you've got very little option when the only option is, and it doesn't matter if you get 10 opinions, it's 10 of the same opinion. This idea that you're getting 10 opinions is pretty much meaningless. It doesn't mean anything. You have to understand, if everybody is educated in the same manner, they're going to just give you the same opinion based on the information that you've given them. Nobody is looking into the concept as, what are all the possible tissues in the area that could be leading to this? Because they're not educated or trained to do that. An orthopedist knows bone, a neurologist knows nerve, a podiatrist knows the foot, a chiropractor knows your spine, right? That's the way it's always going to work. The Yass method, on the other hand, has been open to the idea that it could be a multitude of tissues that are eliciting your symptoms, and the only really way to identify which tissue it is through an interpretation of the symptoms. That's what makes this so unique. That's what makes this an incredible method, primarily from the diagnostic standpoint. If it turns out that it is a muscular deficit, well, that's also where the Yass method separates itself. You could go for physical therapy, you go personal therapy, you get a lot of places to do exercise. You could be told to do Pilates and yoga and aquatic therapy and all this other kind of crap. But the reality is that all of those types of exercises incorporate groups of muscles to perform them. And if there's a weakened muscle, you never isolate that muscle and allow it to eventually work against progressive resistance to where its force output becomes greater than the force requirement of the activities, ultimately leading to where you're pain-free and fully functional. Yassercise, the exercises that are the basis of how we resolve issues in the Yass method, allows you to move one joint in one direction, which is the way muscles work. Typical muscle only moves one joint in one direction. So if you're moving one joint in one direction, the highest probability is that you are in fact isolating a muscle, the muscles that we identified in the physical evaluation. So now all you have to do is use that exercise and cause that muscle to adapt to a resistance. What's a resistance? Well, it could be a resistance band. It could be a dumbbell, a barbell. It could be manual resistance if you really got crazy about it. But some sort of resistance where the muscle is moving through that one joint, one direction through proper range of motion. Now, the whole idea of this is that you're supposed to get the muscle to work against the resistance so the muscle adapts, heals by working against the resistance, and grows more muscle. Eventually, as it grows more muscle, the muscle force output becomes greater than the force requirement of your activities, and therefore it no longer strains and elicits your symptoms. Now, when we talk about symptoms, we'll think about pain, numbness, tingling, but improper posture is a symptom. Improper movement patterns are symptoms, right? Difficulty with function is a symptom. And so what the Yass method does is it interprets all of this to determine primarily whether the cause is muscular or structural. If it's structural, which it is, maybe in 2% of the cases globally, 1 billion people, maybe 2%, maybe less, right? Well, you should go to a structural component person like a neurologist, neurosurgeon, or other, and you get that done. But those other 98% of people, they need to strengthen. And strengthening doesn't come from the medical system. And that's why I irrefutably identify the Yass method as being outside the medical system. Because if you have a muscular deficit, that is not going to be resolved by anybody in the medical system. So if you even remotely can come to the recognition that the high probability is that you have a muscular deficit creating a symptom, you've got one choice and one choice alone, and that is the Yass method. So just to review some of the things we kind of pointed out today, and I hope people who get a chance to watch this really can appreciate the idea that we are trying to give you the information through these tutorials so that you have a better understanding of anatomy, muscle, how muscles work, joints, how joints work, what would be the types of symptoms that would be representative of a structural variation, what would be the symptoms of a muscular deficit. If you get all that information, you can start trying to put this stuff together and help yourself to be able to determine if it's muscular. And if it is, as I said, straight out, then only the Yass method and Yasser size can help to resolve your symptoms. Diane wrote, explain how the gluteus medius can cause a bunion too. So going back to that premise, I'll just do that and we'll kind of finish up here. If we go back to the idea of the gluteus medius, when we talked about if the gluteus medius were weak and it allowed the knee to cave in, instead of weight bearing, just as we said, you would weight bear through the inside of the knee, right? If this is your knee, if this were to cave in, then you could imagine that if you follow that line down, you're not going to be weight bearing through the middle of your foot anymore. You're going to be weight bearing through the inside of the foot. So you have those bones that you stand on called the balls of your feet or metatarsal heads. Instead of weight bearing through all 5 metatarsal heads or balls of feet, you'd end up weight bearing through the first ball of the foot or metatarsal head, right near the big toe. And that is a force that clearly that singular head was not designed to take. It was all 5 balls were supposed to take the weight of your body. So as a result of that excess force, the body's going to say that excess load could potentially fracture that bone, and it doesn't want that to happen, so it's going to create hypertrophic bone growth, excessive bone growth, which is exactly what a bunion is. Now, people, you go to a podiatrist, who's going to guarantee he's going to want to do a bunionectomy. He's trying to say that the bone itself is eliciting the symptom, but you have to be smarter than he or she is, because you say it's only when I weight bear that the bunion hurts. But if I take my weight off, if I sit down, it doesn't hurt. With that very understanding, you must recognize it is not the bone itself that's eliciting the pain. It's the excess force, because you're weight bearing on one ball of the foot, not all 5. And if you simply were to strengthen the gluteus medius muscle that sits up here, this knee, instead of being in, would be out directly under the hip, which means you would be weight bearing directly through the midline of the foot, and you would instantaneously stop the pain associated with that bunion. So you could see, even if we take Diane's issue and go all the way down to the foot, this muscle is the most important muscle in the body. And it is not uncommon for people to have pain here and be told it's caused by arthritis of the hip. Even here, if you look at this muscle, if you notice, what does that say? Piriformis. You can see that the piriformis lies right below the gluteus medius muscle. And if this were to strain, because it's so close, it will have a tendency to want to compensate. So people who have pain in the butt, It's actually a strained piriformis muscle, which is the result of a strained gluteus medius muscle. Now, if you want to take that one step further, if we look at the piriformis straining, you can see that the piriformis runs right across here, diagonally, right? So what is this right here? The sciatic nerve. So what you start to learn is that sciatica, which you have been told is being caused by some structural variation at the lumbar spine, that is absolute nonsense. It is actually the piriformis muscle right here, which strains because the glute med strains, impinging on the sciatic nerve. So you have a muscular cause creating a neurological symptom. So that's that. The final area I just want to reaffirm is the groin area. And just to reinforce that, we have, so if we're talking about that groin area, just remember, if the pain's in here, the highest probability is that you strain your gracilis muscle or the sartorius muscle. But again, these would only strain because the gluteus medius muscle strained first, and it's going to cause the knee to cave in. And once the knee caves in, the length of these two muscles shortens substantially. When they shorten, they lose their ability to create force, which ultimately is why they strain. So pain in the groin area typically is not simply caused by something in the groin area. It is caused by strained muscle that sits at the side of the pelvis above the hip joint, which is the gluteus medius muscle. I'm just going to put down here my email address. So to kind of summarize, if anybody feels that they've learned something from this, that they're more equipped to understand the cause of their symptoms in the hip region, and you want to reach out to me, I'm going to put my email address, drmitch@mitchellyass.com. So it's right there. So if anyone needs to reach me, you can certainly reach me. If you would like an opportunity to get treated through the Yass method with the coronavirus and the isolation and the social distancing, you still have the opportunity to do it through some sort of teleconferencing system, whether it's Skype, whether it's FaceTime, whether it's Zoom. It really doesn't matter to me. We could always do that. If you'd like to make an appointment, please contact me at drmitch@mitchellyass.com. If you're liking what you're seeing and hearing, and you see this as a path to understanding why, after all the treatments, the medications, the doctor's visits, the money spent, the time, you're still suffering, well, please subscribe to my channel. The more people subscribe, the higher in Google I get, the greater the number of people that Google will send this information out to. There really is no alternative to the Yass method that exists other than the existing medical establishment, and the existing medical establishment has shown itself to have failed. It is a failed system, and they're unwilling to acknowledge that the failure comes in the very initial attempt to diagnose the cause of your symptoms, because they primarily use diagnostic testing. If you recognize that as the failure, well, there's nobody else to go to within the system. You have to go outside the system. That's what the Yass method is there for. It is, I'd rather it not be, but right now it is kind of the last resort for people. I'd rather it be the primary resort. I'd rather you say to yourself, oh my God, it makes more sense that it's muscular. Every time I do an activity, it gets worse. If I take a shower and I get hot water on it, or I put a menthol patch on, it gets better, right? If I do the activity, then I rest. When I rest, it gets better, right? All these types of things should be able to make you aware that it's a muscular cause. Well, you're not going to get that answer or that ability to resolve that in the medical system. So please see the Yass method as an alternative. Let people know if you've heard about me, if you've heard about the Yass method. I've been out there. I've done a PBS special called The Pain Prescription, which had from 2015 to 2017. I have 3 books Overpower Pain, the Painkiller RX, and the Yass Method for Pain-Free Movement. The latter two being published by Hay House Publishing. I write for What Doctors Don't Tell You, which is an international magazine sold in 20 countries, translated into 14 languages. I've been treating for 27 years, over 15,000 people. I believe my credentials are unbesmirched at this point. I mean, I don't know how anyone could say that I don't have every bit of credential which would justify at least looking into the chance that maybe the cause of your symptom is muscular before you're willing to get a surgery, which you can't undo. And with the failure rates being what they are, I don't think people understand. 22 million Americans addicted to prescription pain medication. That is no accident. All the increases in depression and suicidal rates all go up. You think that's an accident? The primary reason for this rise is the fact that people can't stand being in pain anymore. And they don't know who to look to or for. And that's what the Yass method stands for. So please let people know. You have access to YouTube. You have access to my Facebook page, which is at the Yass method. Go to my website, mitchellyass.com. Go to the blog section. There's 60, 70 videos and blog posts that will help you to understand why the Yass method works. I've put unlimited amounts of information out there. All you have to do is get the information, and then you could begin to see that there is a light at the end of the tunnel. Hopelessness, depression, and suicide does not have to be your life. There are so many people, way too many people, who think that that's all there is. There isn't. There is something so completely different than anything that exists out there. You just have to be willing to seek it out and just see if it makes sense to you. And if it makes sense to you, then try it. I'm here. If anybody wants to reach me again, you could always reach me through email, drmitch@mitchellyass.com. Please subscribe to this channel. I think that's an hour now, so we're going to call it quits for now. This is Dr. Mitchell Yass wishing you a pain-free, fully functional life. Bye-bye for now.